Good morning, good afternoon, wherever you are. Welcome, welcome. I'll give this another second until we have a couple of people here. Welcome to another YouTube Live. My name is Patrick Hutzel from Intensive Care Hotline and Intensive Care at Home. I'm here today to answer all your questions intensive care and intensive care related. This live stream is for families in intensive care. And we can answer all of I can answer all of your questions today here on the live stream. You can either type those questions into the chat pad, or you can call in live on the show. I put the numbers into the chat pad. You can dial in live on the show. I want to welcome you again. Give the video a like, share the video with your friends and families, and subscribe to my YouTube channel for regular updates and for regular live streams here on YouTube, where I answer all your questions. But we're also broadcasting now to other platforms such as Facebook, Twitter, LinkedIn, so that other viewers have the opportunity to come in as well. Now, before we get into today's questions, just in case you're wondering what makes me qualified to answer your questions about intensive care and intensive care at home, I am a critical care / intensive care nurse. I have worked in intensive care for over 20 years in 3 different countries. I have also worked as a nurse unit manager in intensive care for over 5 years. As part of this, I have been consulting and advocating for families in intensive care as part of my professional consulting and advocacy service here at the Intensive Care Hotline for nearly 10 years. And I'm also the founder of Intensive Care at Home, where we send long-term intensive care patients into the home, predominantly with ventilation and tracheostomy, invasive ventilation, but also non-invasive ventilation, such as BiPAP and CPAP. And we're also providing home TPN. So I can answer all of your questions, intensive care and intensive care at home related. So please shoot away. Shannon, welcome Shannon to the call. And Shannon says, is recovery from hypoxic brain injury different from a recovery from a TBI? Look, it really depends. I mean, how severe is the hypoxic brain injury and how severe is the TBI? There are different stages of TBI. There are different stages of hypoxic brain injury. Someone might say that a concussion is a traumatic brain injury, but a concussion is then, should be dealt with within a few days or within a few weeks. So it really depends on the severity. Also, for example, a traumatic brain injury, has there been a bleed? Has there been no bleed? Is there midline shift? Right. So sometimes with a traumatic brain injury, the midline of the brain can shift to the left or to the right, putting a lot of pressure on the brain. The best way to find this out is with a CT scan or with an MRI scan. Now, another thing that happens with a TBI, many TBIs in intensive care have an ICP in the brain or an EVD. So what that means is an EVD stands for an extraventricular drain, and where CSF is drained. CSF is the brain or spinal fluid. Okay, so once that's drained, you're getting CSF, but you can also check an ICP, for example, and depending on the ICP, what's the intracranial pressure, you can check on the severity of a brain injury. So, and with a hypoxic brain injury, again, it really depends on how severe is the hypoxic brain injury. Have you seen a CT scan for your loved one? Have you seen an MRI scan? Have you spoken to a neurologist? It would be great, Shannon, if you had more information about your situation in particular. So you can dial in live on the show. I've given you the numbers, or you can continue the conversation here in the chat pad. Hi, Tim. Nice to see you. Thanks for your comment. So, Shannon, while I'm waiting for your comment, I will just read out some questions that I had during the week. I just need to bring them up on my emails. So, Shannon, if you can give me more information, that would be great. And in the meantime, while I'm waiting for more information, I will just bring up the question that I had during the week. So Shannon, you're saying, I have a friend who was minimal conscious after he coded 12 minutes after surgery. I have a friend who was minimally conscious after he coded 12 minutes after surgery. The MRI showed diffuse abnormalities. Right, okay. So if he coded for 12 minutes, the question really is, did he code for 12 minutes and he had no oxygen to the brain, right? If he coded for 12 minutes and he always had oxygen to the brain, maybe he has no hypoxic brain injury. I really don't know. So it would be really good to know what is the exact details. Diffuse abnormalities, like the word you said, it's diffuse. Now bear in mind, Shannon, I am not a neurologist. I'm talking from experience here. Recovery with hypoxic brain injuries or with TBIs can take a long time, and there's no guarantee for recovery. It's definitely concerning that he coded for 12 minutes. But bear in mind, it sounds like he was in a hospital after surgery, so he's been in the best of places, really. So imagine this would have been an out-of-hospital arrest, where it might have taken minutes to get an ambulance. So if he coded in the hospital, he would have had, the medical emergency probably jumping in at the drop of a hat, whereas an out-of-hospital arrest is generally speaking has poorer outcomes. So you're saying hypoxic encephalopathy. Yeah, that sounds definitely concerning. That sounds definitely concerning. Question is, how many days has he been unconscious for, or has he been unconscious for at all? Is he having seizures? Is he, waking up at all? Has he been on sedation? It's not as simple as, how long does it take to recover? It's a case of, what else is happening? Is he having seizures? Has he been in an induced coma? I presume yes. Has he been in an induced coma? What sedatives did he have? Does he have any pre-medical history? It really depends on a number of things to determine how long will it take for him to wake up. Now, hypoxic encephalopathy is definitely concerning. There's no question about that. But you can see it's not a one-size-fits-all, and there may be some people that say, look, if I have hypoxic encephalopathy, I do not want to live. And then there are others who might say, well, other families that might say, well, I definitely want to give it a good shot for my friend or for my family member to wake up, So, it's not a one-size-fits-all, and there are clients living at home with a hypoxic encephalopathy, and they might be perfectly happy to live, to be alive. This is not a one-size-fits-all. I know that people are looking for answers. People are looking for answers, to have, to that someone says to them, yep, it'll take 3 weeks, it'll take 3 months for them to wake up, and then they have restored their full functionality. It's not a one-size-fits-all. There are so many variables. And I know you're looking for a clear-cut answer here, Shannon. I can't give you that clear-cut answer. Even if I had access to the medical records, we would look at medical records, we could probably give you a better idea. But even then, there are many, many variables in terms of what the outcome could be. I hope that helps. And also in the beginning you asked, is hypoxic brain injury different from recovery from a TBI? A TBI can actually cause a hypoxic brain injury, depending on what's happening. Okay, now you're saying, Shannon, he's now having dialysis 3 times a week due to kidney failure, also severe compartment syndrome to his arm. He has his eyes open but not responding, no sedation for the last 2 weeks. Okay, right, okay. So he's still having dialysis 3 times a week. severe compartment syndrome to his arm. Wow. So there's a fair bit going on there. With a compartment syndrome, sometimes what I've seen over the years when I worked in intensive care, patients go for hyperbaric therapy to have the compartment syndrome treated. So you may want to ask for that. With the dialysis, that's definitely a concern. You know, why does he need dialysis all of a sudden? Was he a dialysis patient before he had the downtime, before he had the cardiac arrest? I presume he had a cardiac arrest from what you're sharing with me. No sedation for the last 2 weeks. Right. I see. Okay. Other question here, Shannon, are, is he getting mobilized? Is he getting stimulated? You know, is he getting out of bed? You know, does he have visitors that talk to him? Do they play his favorite music? You know, do they surround him with pictures maybe from his families or friends? You know, those are all critical questions that you might want to ask in a situation like that. You know, is he, you know, imagine you're lying in bed for 3 weeks, you know, and you're not getting up. You know, your brain is probably not getting stimulated by that, you know. So you can see where I'm going with this, that, you know, stimulation is going to be important. Is there a reason why he can't get mobilized, for example? You know, does he have any fractures? Is the compartment syndrome potentially stopping him from getting mobilized? I doubt it. But, you know, you may want to ask all of those questions. You know, is he getting the right nursing care? You know, is he getting turned every 2 hours? Is he having good washes? Is he having mouth care? Is he potentially having a shower? All possible, even though you might think it's not possible in ICU. A good ICU will put their patients in a shower, even in a shower trolley, even if they're on a ventilator. It really depends, you know, which ICU your friend is at. But critically important, you do need to get an assessment from a neurologist in a situation like that. Where does the neurologist see this going? You know, the other question that I have in a situation like that, Shannon, is he ventilated? Does he have an unstable airway? Is he still ventilated? Does he have a tracheostomy? Is he not ventilated but has a tracheostomy? Can he manage his own airway? You know, those are all critical questions to ask. You know, as I keep saying over and over again, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And that's a big challenge for families in intensive care, or for friends. So, and if you happen to be the power of attorney, Shannon, you know, I don't know whether you are or you aren't, you know, access to medical records would be important for you and for the family to understand what's really going on. You know, we're just scratching the surface here in terms of your friend's situation. You know, there's so many missing pieces in order to really help you with how long will it take for your friend to wake up? Does he have a chance of recovery? If he does have a chance of recovery, what does it look like? What are the predictions? Will he benefit from neuro rehab? You know, so all these questions. Okay, what other questions are there? If there are no other questions, or Shannon, if you want to add on any extra details, I can certainly come back to your question. In the meantime, I'll just go through my emails from this week, and I'll just need to bring them up, and I'll read out the questions that we have this week, and we'll answer them for you here. Now, just give me a second. It is. Okay, Cocaine has written in this week. Cocaine says, my dad is in ICU due to severe hypoxic ischemic encephalopathy. Oh, there you go. Similar to your question, Shannon. The doctors say there is no chance of recovery for him, but as we're seeing my dad, he's opening eyes after 16 days, but no pupil movement. Also, his throat and his body are shaking, looking like they want to talk to us. please guide and help me, as the doctors are saying we should withdraw life support. We don't understand what to do next. Well, that's a very difficult situation, Cocaine, but similar to what I just said to Shannon, that, you know, your dad's hypoxic brain injury might be very severe, you know, and the doctors might say there is no chance of recovery. It's now 16 days, but you can see pupil movement and you can see that his body is shaking like they want to talk to you. You know, so have a think about it, Cocaine. Would you project yourself 12 months out from today? If you were to make a decision after 16 days in ICU to withdraw life support, would you potentially regret that in a year's time? Would you wait another 16 days now and see how things are progressing, you know, and then make a decision? So always project yourself 12 months out from today, whether you would regret a decision that you would make today. We have many families coming to us here, and they say, oh, you know, 12 months ago, 24 months ago, we decided to withdraw treatment on our mum, on our dad, and now I'm having second thoughts that I killed my mum by letting that happen. What would have happened if we just would have continued for a few more days and see how it went? You know, so you really have to approach it from that angle, because, you know, those situations are highly emotionally charged, and you should not jump to conclusions. You should not, you know, make decisions at the spur of a moment because the ICU needs a bed, for example, right? Because that's what it often is. ICUs need bed. They try to, quote unquote, sell you on a withdrawal of treatment right there and then. The worst case scenario for an ICU is to look after someone indefinitely with an uncertain outcome, and that is your dad's situation. You haven't shared whether your dad now has, for example, a tracheostomy or not. You know, does he need a tracheostomy as a next step? Because that'll give him time to recover and wake up. You know, and similar to what I said to Shannon before, is he getting mobilized? Is he getting stimulated? Is there anything stopping him from getting mobilized? You know, is he having a shower every day? Is he having good washes? Is he having good mouth care? Do you play him his favorite music? You know, does he have seizures as part of this condition? Is he still sedated? Is he still having anticonvulsants, anti-epileptic medicine? All these questions that need to be answered, you know. So I hope that helps, Cocaine. Let me move on to the next question, but before I do that, I just need to moisten my throat. Also wanna welcome the viewers that are, you know, watching this on recording once it's been uploaded. Want to thank you as well to watch this video. So, next question. Next question is from Paul. Paul says, my mother is in ICU on a ventilator and was found unresponsive due to low sugars. They sedated her, giving her propofol and Versed, and also seizure medications because she started having seizures as well. They did an MRI a few days ago and no brain damage was found. There have been no more seizures, and they began weaning her off the Versed and propofol, and all the seizure medications yesterday were removed as well. How long will it take for my mom to wake up? They had her on a heavy amount of sedation medications. That's a great question, Paul. So again, it really depends. Now, if she was on propofol and Versed, that's heavy stuff. You haven't shared how many days she's been on it. you haven't shared whether she's waking up at all. So the difference between propofol and Versed is, generally speaking, that propofol is short acting. So when you put someone in a coma with propofol, it works really quickly, and patients should also wake up quickly. With midazolam, on the other hand, you have a long-acting sedative. That means, depending on how much midazolam you give, patients sometimes do not wake up pretty quickly. Now, also with your mom having had seizures, I'm not surprised that she had Versed and propofol, because Versed is a benzodiazepine and can be given for seizures. Okay, so I'm not surprised that she had the mix of both. It's good that they got the sugars under control. It's good that they managed the seizures. It's good that they've done an MRI scan which showed no brain damage. That is really fantastic. Now it's probably a bit of a waiting game. So here is what sometimes happens in ICU, what I've seen over the years. Patients have no brain damage. They've been in an induced coma for a few days and they're not waking up quickly. So waking up after an induced coma is like switching on a light with a dimmer. It's not like you're switching on a light and bang, the lights are on, right? Now, some patients wake up very quickly if they've been in a coma for less than 24 hours, but that doesn't sound like was the case in your mom's situation. They had to get the sugars under control. They had to get the seizures under control first. So, that's what's happened here. Other things that come into play when it comes to waking up after an induced coma, Paul, is so many patients in ICU have impaired kidneys and they have impaired liver function sometimes because of all the medications they're getting. So if that is the case, then sedation can not get metabolized or excreted as quickly as, with a healthy liver or with a healthy kidney. So that can put a delay on waking up as well. Overall, you got to be very patient with your loved one waking up here. Also, sometimes patients, because of their critical illness, they don't wake up straight away because they're critically ill, and they just take their time. No amount of time can speed up the process of waking up because people are just crook, for lack of a better term, and they need time, they need a lot of TLC, and they need patience, quite literally. You got to be patient here. Most important thing is that you can see progress. Most important is that she doesn't have any more seizures. Most important is that you are with your mom and talk her through it, If, God forbid, she's still not waking up in a week's time, she probably needs another MRI scan or CT scan of the brain. You've got to rule out a neurological event like something like a seizure, a stroke, or a TIA. So that certainly, it's got to be monitored all the time. And, if she's not waking up, they need to check her pupils, they need to check her reflexes and all of that. But I don't think at the moment there's any need for panic because she's just been very sick and she needs time to wake up. I hope that helps, Paul, to answer your question. I've written about this extensively. I also have got a couple of ebooks about, how long does it take to wake up after an induced coma, mistakes that you're making in being impatient, and so forth. So we can link underneath this video after we've published the video. Okay, next question. Next question comes from Claire. Claire writes, my father is a COPD patient and was admitted to hospital on December the 30th with COPD exacerbation. He was having an elevated CO2 level at 130 millimeter per mercury. Before that night, my mother made arrangement for oxygen supply, but without consulting a doctor about how much oxygen he would need. Wow. At that point, his oxygen level was 90%, so I assume he didn't need oxygen at that time, because 90% is okay for a patient with COPD. Now, before I go further, you're absolutely right that oxygen supply for a COPD patient should not be made without consultation with the doctor, because it can reduce the respiratory drive. And 90% oxygen saturation is just about okay for a COPD patient, from my experience. But you should also have goals. You should have from the doctor saying, yeah, we want an oxygen saturation of greater 90 or greater 92. So, it's not quite accurate to say that 90% is good enough. It comes down to the goals that need to be achieved, and that should be directed by a doctor. Next, you're saying, but since my father felt temporary relief with the oxygen cylinder, he was having trouble breathing. He slept with the oxygen supply for the whole night. The next day, he was feeling okay. I talked to him over the phone, but after I hung up, I got the news that he had to be admitted to hospital urgently because he was about to be unconscious. At the hospital, they checked his CO2 level, which had risen to 130 millimeter per mercury. Just for the records, normal CO2 levels are 35 to 45 millimeters per mercury, and he had CO2 levels of 130. They immediately put him on a ventilator to reduce the CO2 level. The CO2 level took some time to go down. After that, he was temporarily on BiPAP, I believe. I'm not physically present there. Yeah, you're probably right that he would have been on BiPAP. BiPAP is the ventilation mode of choice to begin with to get CO2 down. Now, what you haven't shared yet is whether your dad was intubated or not, but maybe that's later down in the email. There's still some reading I have to do there with the email. So let's find out whether your dad was intubated or whether he was on BiPAP just non-invasively with a mask. So after that, since they used some blood thinners during the ventilation, that caused some internal bleeding and hematoma. For that, he had to have 5 units of blood transfusions. Ever since he's been on the ventilator, they're trying to wean him off the ventilator, but no luck yet. They also did a tracheostomy on him. Okay, so now I understand what's happening. Maybe he was on BiPAP with a mask initially, but then they probably had to intubate him because maybe he couldn't maintain an airway without a breathing tube, because maybe he was confused or unconscious with such high CO2 levels. Now, having said that, most COPD or asthma patients have a higher tolerance level for CO2. So maybe his baseline CO2 is 60 or 70, I don't know. But COPD or asthma patients have a higher threshold for CO2 level, baseline CO2 level. So now he's got a tracheostomy. He was better the day before yesterday and breathed for around 12 hours with 50% ventilation support. Okay, so a lot of families come to us and say, oh, he's breathing, he or she or whoever they're referring to is breathing 50% on the ventilator. That is often not accurate, and I'll tell you why. So when someone is on a ventilator, there are many different ventilation modes. So you need to look at the ventilation mode. You need to look how many breaths is someone taking per minute. Are the breaths spontaneously triggered, or are the breaths mandatory breaths delivered by the machine? Okay, so that's number one. Number two, what are arterial blood gases? How much FiO2 is your dad on? Right, you mentioned 50%. What's his PEEP? What's his pressure support? What's his BiPAP level? What are the volumes he's breathing? So to say he's breathing on 50% of oxygen it's a very broad statement, and it doesn't really mean anything, right? So let's move on. But then they said the next day he was drowsy and needed to be put back into full ventilation support again. Okay, so if he's become drowsy, there's a number of reasons why he could become drowsy. Maybe he has more sedation needs. Maybe his CO2 was rising again. High CO2 makes patients drowsy, right? God forbid, has he had a stroke? God forbid, has he had a seizure? Why is he drowsy? You got to find out. And there could be other reasons as well. It could be from other side effects of medications, for example. So please find out, why is he drowsy? Yesterday, they also said that he's having some infection pneumonia, to which they need to do a bronchoscopy and lung cleaning. Sure. So it sounds to me like starting with a high CO2 now is ending up with an infection or pneumonia, in which they need to do a bronchoscopy to do some lung cleaning. Yeah, that might help if he has a lot of secretions on his chest and they can't suck them out. Maybe a bronchoscopy would be helpful to clean the lungs, improve oxygen saturation, improve arterial blood gases, improve chest x-rays, and increase the chances of getting him off the ventilator and get the pneumonia cleared. So that bronchoscopy was done yesterday. We are yet to get an update about his current status, but he needs to be weaned off the ventilator as soon as possible. Absolutely. So, you haven't shared why he's had the tracheostomy. It's not clear to me. In any case, he needs to be weaned off the ventilator 100%. And the way to do that is get rid of all sedation, start mobilizing him. One way to get someone off the ventilator quicker is to do a tracheostomy. You can stop sedation. It's much more comfortable for a patient to have a tracheostomy compared to a breathing tube in the mouth. And then you can start mobilizing them, start more physical therapy, get them out of bed. From what I'm reading, it's not quite clear what stops your dad from getting off the ventilator. I would need more information, but clearly from my experience, he needs to start mobilizing physical therapy and physiotherapy, deep breathing exercises, coughing exercises, monitor, does he need frequent suctioning, monitor arterial blood gases, monitor his respiratory drive, monitor, can they wean off the ventilator? Can they, if he's breathing, for example, with 20 breaths per minute, let's just say he's breathing with 20 breaths per minute, delivered by the machine, guaranteed breaths per minute by the machine, and let's just say he's breathing on top of that spontaneously. Can the 20 minutes per breaths delivered by the machine wean down? Can they wean down to 10? Can they be weaned down to 10 breaths per minute? And then he breathes on top of that, right? But then you also need to make sure that the volumes he's breathing spontaneously are the same. They're not being delivered from the machine. So if he's getting 500 mils from the machine, he should also breathe 500 mils spontaneously. If he's not breathing what's adequate to his weight, he will be in trouble with weaning off the ventilator, right? So there's obviously huge psychological aspects when it comes to weaning off a ventilator. Some patients might report they're now psychologically dependent on the ventilator. There's a lot of coaching that needs to go through. They need to go through. There's a lot of TLC, a lot of explaining, a lot of holding hands, a lot of encouragement, a lot of things like, if in ICU, the patient, for example, is in a dark room with no natural daylight, get them into a room ideally with natural daylight. If, God forbid, all of that fails, well, there's a service like intensive care at home, where we provide intensive care at home nursing for patients that can't be weaned off the ventilator with a tracheostomy, but also on BiPAP or on CPAP. We are currently operating in all major metropolitan areas in Australia with intensive care at home. But even if you're watching this and you're in the US or in the UK, you should contact us as well. But definitely in Australia, we can take you home pretty much in any area. So I hope that helps, Claire, to put light on your dad's situation. Now, I'll just need to moisten my throat again before we carry on. Let's move along to the next question. The next question is from Tammy. Tammy writes in, my fiance is in ICU. He had a drug overdose. He was having seizures, which now he's on 3 medicines which have the seizures under control. He has a pneumonia, which is getting better. He has brain damage due to the time he went without oxygen. He's breathing over the ventilator at times. What are his chances? Look, very difficult to say, but here is what you should know. I presume your fiance is young. That's definitely a benefit and a bonus for him. What you also should know is, roughly 90% of ICU patients survive and they leave intensive care alive. Now, I'm not talking here what their quality of life looks like down the line, but I'm telling you that most ICU patients survive. So if he's having seizures and he's now been on 3 medicines which have the seizures under control, that's certainly a good sign, but it'll probably also make him sedated still, which might delay him waking up. So if he's having a pneumonia, I would also imagine he's on antibiotics, obviously, and he's still on a ventilator. So now the next step is, you haven't talked about a tracheostomy, so I presume your fiance is still ventilated with a breathing tube, and he's ventilated in whatever mode he's in, but he might still be in a controlled mode, such as SIMV, CMV, where the machine is doing most of the work, right? So if you're concerned about his oxygen levels, you talked about he went without oxygen during, the overdose. That is certainly a concern. And if he's having seizures, that could be a sign that his brain is somewhat damaged. In a situation like that, you should be talking to a neurologist and find out what they are saying about can he recover. It's good to hear that he's breathing over the ventilator at times, but that's not what needs to happen for someone to come off a ventilator is they need to be awake, they need to be able to obey commands, they need to be able to have a good cough, they need to be able to move their limbs on purpose, purposeful movements, minimal secretions. It's almost like they need to be able to cough out that tube independently, and they need to be in a position where they could rip out the tube independently. Not that I advise they should do that, because they could damage their vocal cords and their windpipe, their trachea. Taking out the breathing tube needs to be done by a professional, But generally speaking, your fiance still has a few battles to overcome. So the battles he needs to overcome is, 1, he needs to clear the pneumonia. Okay. 2, he needs to be seizure-free, ideally. 3, they need to wean down the seizure medicines, whatever they are, to a degree so that he can wake up and that he then can be weaned off the ventilator, that he can be coached through weaning off the ventilator. So with the brain damage, again, I do believe you do need to speak to a neurologist and find out what the neurologist says about your fiance's future. Other things that need to be looked at in a situation like that is blood results, for example. If he's had a drug overdose, is his liver working? If his liver is impaired or kidneys are impaired, maybe he's not waking up because sedation and drugs are still in his body and can't be metabolized and can't be washed out through the kidneys. So that could have a delaying effect as well. So again, it comes back to the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. They don't know how to manage doctors and nurses in intensive care. And this is, again, what you're dealing with here. Another thing you should be doing is you should be requesting access to medical records, assuming you are the power of attorney. Also send me a picture of the ventilator. Send me a picture of the monitor. Send me a chest X-ray report. Send me an MRI scan report, CT scan report. We can look at all of that. Part of what we do is interpret medical information and also review medical records as well. So I hope that helps, and we can move on to the next question. The next question, and this is more of a frequently asked question that I want to talk about, but before I come to that question, just give me 1 second, and again I need to moisten my throat, and I'll be right back. Just take a minute break and I'll be right back. Okay, I'm back. So this is more of a frequently asked questions from clients, and I have made a quick tip video about it that I think we published already. But a question that we get frequently is, can you die while on BiPAP? So that's a great question. Now, again, the answer, like with many questions in the medical field, are that it depends, you know. So I'll give you some scenarios that you can see that sometimes BiPAP can be a lifesaver, and sometimes BiPAP can also be a mechanism to help someone approach their end of life. So let's just say you have a patient in ICU that has a pneumonia, is on a ventilator with a breathing tube, and eventually you extubate them. The pneumonia is nearly cleared, but the patient is too weak to breathe and still struggling to breathe, and still has, some collapsed areas in the lungs, still has some atelectasis. Then putting a patient on BiPAP after extubation, after the breathing tube is removed, will only aid them in the recovery process and can be a very good thing to help them, on their way to recovery. Many patients in ICU, pre and post extubation, need BiPAP, right, to aid them in the recovery and the treatment process. So BiPAP can be a beautiful thing. It can be very uncomfortable, but it can be a beautiful thing. Are there patients that potentially approach the end of life on BiPAP? Absolutely. For example, with intensive care at home, we've just had a palliative care situation at home for a gentleman with lung cancer, and he was very BiPAP dependent for the last 3 months of his life. And we provided palliative care with intensive care at home for someone who was BiPAP dependent 24 hours a day. But this gentleman did not want to be in ICU, and he wanted to be at home for his last few months of his life. And I believe we, provided everything for this man to make his end of life as comfortable as possible, and for his family as well. But what we also did in the process, we kept an ICU bed empty. It would have cost $6,000 per bed day to have this man in ICU for 3 months, whereas we kept him home for 3 months for half of the cost. But it's not about the money, it's about what do people want? Where do people want to approach the end of life? So, if we had taken off the BiPAP 2 months before he passed away, he would have passed away anyway, because he was so BiPAP dependent because of the lung cancer. But, it's again, with a question like this, can you die while you're on BiPAP? It's like with a lot of questions in ICU, the answer is often, it depends. We've had other clients at home with intensive care at home that have been on BiPAP and that are on BiPAP, for example, and where in some situations it helps them to improve their quality of life, it helps them to prolong their life, but then they might be on BiPAP right up until the end of their life, like we've had before. We also have clients at home, for example, with spinal muscular atrophy, SMA. We have kids at home on BiPAP. Can they die while they're on BiPAP? Look, there's always a risk, but that's also why an intensive care nurse needs to be there 24 hours a day to avoid that. If you look at the mechanical home ventilation guidelines on our website, Intensive Care at Home, it's clear that anyone at home on a tracheostomy ventilation, but even BiPAP, CPAP without tracheostomy, need to have an intensive care nurse 24 hours a day to make it safe. Right, those are from the evidence-based mechanical home ventilation guidelines, and they are on our website. So I hope that explains that, can you die while on BiPAP? Again, the answer is that it depends. So I hope that helps, and I want to close this off for this week, unless you have any other questions. If you have any other questions, please, now's your chance to ask them. If you're watching the replay, just put your questions in the comment section and I will get to them, or just simply send us an email to support@intensivecarehotline.com with your question. But even better, if you have a loved one in intensive care, go to intensivecarehotline.com and call us on one of the numbers on the top of our website. Now, also, If you have a loved one in intensive care and you want to go home with ventilation and tracheostomy or with BiPAP ventilation, just like we explained now, or even with a tracheostomy without ventilation, you will need an intensive care nurse 24 hours a day at home in order to leave the hospital safely, in order to leave ICU safely. If that's you or your loved one, please contact us at intensivecarehome.com on one of the numbers on the top of our website. Now, also have a look at our membership for families in intensive care. That's at intensivecaresupport.org. There we have a membership for families in intensive care, and you have access to me and my team 24 hours a day in a membership area and via email, and we answer all questions intensive care and intensive care at home related. If you need a medical record review, we do that as well. We review medical records for patients in ICU. We can do that for your loved one in ICU in real time. We can help you get access to the medical records and review them in real time, or we can review them after intensive care, especially if you're suspecting medical negligence. Also, subscribe to my YouTube channel for regular updates for families in intensive care, and also for those YouTube live streams. Like the video, click the notification bell, and comment below what you want to see next or what questions and insights you have. Thank you so much for watching. This is Patrick Hutzel from intensivecarehotline.com and Intensive Care at Home, and I'll talk to you during the week and next week with my quick tip videos, and next week in another YouTube live stream. Take care for now.